Thank you for asking me to and give me the honor to speak for the I would say for the GPs from Croatia, and because we have a very tight schedule, and we had a lunch, and now we are a little bit sleepy. I prepared a pop quiz to wake you up, and the question is, who is the most famous GP in the last 2 decades? The one that we can read in the newspapers, the one that books were published about, and do you have idea? Of course, of course. Our colleagues from UK, of course, know that. It proves not only that the GP's work looks like a work of housewives. When everything goes very smooth, nobody can see that anything has been done. And if the dust is on a TV set, then everybody see that there are some troubles. But I think it learns us how difficult it is to recognize quality of GP's work, especially for the lay people, and to understand the concept of quality in a primary healthcare. It learns us how important it is to perform quality assessment if nobody else wants that GP have to do it by themselves. And finally, it learns, especially colleagues from UK, what can happen if you fail to do so. So if we come to the Croatia, I cannot say that something like that cannot happen in Croatia. I won't sign on that. About licensing of the doctors or accreditation of the doctors, about their capability to work, we have a well-organized system. Croatian Medical Chamber is issuing a license to work. You have, when you finish the state exam, you get a license, and you have to relicense in a 6-year period, mostly with getting points from the CMA and publishing, but some other activities also. We are now in a 3rd cycle. We started in 1996, so we are now in 3rd cycle, so we can say that we have experience about that, and this process is going almost well. What does it mean? It means that weak point for the general practice is entering point. We have good, long experience with vocational training in general practice starting in the 60s. We have a well-tailored program, but it is not compulsory to get a license to work in general practice. It is not only a bad thing for the entering of the young doctors, but also everybody who has a license to work in a health service can work in a general practice. So you get your license every 6 years, and if you work in 20 years as a surgeon, you still have a license to work in general practice. As I said, that the weak point for the doctors is entering point. Strong point for the practices is entering point. So there are very strict rules about space, equipment, working schedule, what you have to prepare when you start the practice. And afterwards, there is no systematic reviewing of what you are doing. Of course, we have on paper a regular control, we have on paper incidental control, but financing of this system is not defined. So there is, everybody said there is no money to perform regular control, and it came up that incidental control, critical incident control, is the only control that is living now. If somebody goes wrong, then we have a control. So the golden time or the best time of some practices is their starting point. And everything what happened afterwards is just declining. So there is no any stimulation for progress, and you are not checked about accreditation afterwards. I have to announce that there is some checkings that you have to do according to the instruments, the calibration of the instruments that you work with, and also some of the health medicine producers, the people who product equipment, also have some sort of regular control in a purpose that they can guarantee the quality of their products. When we speak about process of work and how we look at the process, we have two codes that we have to devote to every contact to the patients. One is morbidity code, and another is medical procedure code. Most of you now think about ICPC, but it is not about ICPC. We use ICD-10 code for the morbidity, and we use several schemes for coding the procedures. A morbidity code, together with some specific procedures in preventive and curative care, have to be yearly reported to the Health Institute of Public Health, and according to that data, we have a Croatian healthcare yearbook where you can see morbidity structure of the people coming in primary healthcare, also some basic figures about job done in the primary healthcare. On the other side, we have a compulsory monthly report of every procedure what we perform. A book means the procedure that we do within a scheme of capitation fee. DTP code means the procedures we perform in a scheme of fee for service, and preventive care especially. All of this we report to the Croatian Institute for Health Insurance, but what we see out of that, we see almost none. What does it mean that we see almost none? It means that we don't have a yearbook. We don't have a benchmarks that I can say which is how I swim in that. According to average of other people. We don't have the data of that kind. And what are these reports used? They are used to control utilization of the healthcare, and they are also used for controlling the contractual obligations, including punishment to the GPs who don't fulfill all obligations. What can general practitioner do in that world? So we are not just complaining. You can see here in the last 10 years what the general profession of general practice have done in Croatia. So some of these instruments you know and were already mentioned here: EuroPEP test or Croatian Quality Index, Patient Enablement Index. This is something that you already know, but there are some also that were produced among general practitioners. And I put here something that is very, I think, very important also to the question that was also mentioned here. In developing 25 indicators instrument, we have Ministry of Health as a partner. In Croatian index, in a scheme of new contract quality, we have a Croatian Institute for Health Insurance and Croatian Ministry of Health as a partners, as a stakeholders who signed that contract, new contract. And for EuroPEP, after a series of testing made by the doctors by themselves, we have also one big research made by the Ministry of Health. What we noticed in this, that these stakeholders were not very good partners in a way of sustainability or continuity of what we are doing. So as a government change, everything collapsed. For example, the new contract quality index was signed and prepared for use and never came alive because our government changed. Just to make an overview of these three instruments made in Croatia, I think that they are they are very much the same as some instruments that we already seen here. These are in the breaks. You can see the number of the indicators in some groups. 25 indicators. So it describes structure, procedure profile, result of performance. Procedure profile means what the practice can offer to the patients. Then a patient perspective in a certain way, and then last, as a professional task, means what the GP is doing within a professional organization. Is he contributing to education or political involvement in arranging contracts and so on. New contract quality index also had a preventive in screening and health education, prescription index in antibiotics, and prescription index in antihypertensive drugs. The index is something that is it came from our observation that we have a lot of data of the process that are not used. So these data were meshed and put in rates in a way that you can have a better insight is what is going in a process of work. And the rates are procedures per patient or prescriptions per procedures or procedures versus other procedures. You see that some of two of these three are tested, but a new contract, as I also already mentioned, was never tested. What we have learned? We have learned that the state or government involvement do not guarantee continuity. This is something that was very hard to. We are pretty sure that if we have a ministry on our side, that everything will come to implementation. But it's in a 10 years period we saw that it is not the truth. We also have designed and tested quality indicators that exist for, and it can be performed in a Croatian system. We are fed up with the reports that we sent in to the different institutions and that are not used or are misused. We are really not satisfied that everything what you can get in this system is some sort of punishment, and there is no quality improvement stimulation. And I can say at the end that the difference of opinions between the GPs themselves is also a constant obstacle. We are individuals, and we do like to think that we know the best. And this is something also that showed to be very, very, very important. These emblems there at the end are the four societies of general practitioners functioning now in Croatia, and you know then out of that you can see that there are different opinions among general practitioners professionals. And what we Croatian GPs want, we would like to have independent body, agency. I'm not sure that what we have now is independent agency. Because it would be independent agency if we started to accreditate and pay some, invest something in that and then get independent body. You see that it started to, announcement of agency started 5 years ago. It started to work 3 years ago, but still is not, it doesn't have independent financing, so the government is involved very much. We do like to have accreditation and re-accreditation of the practices. What you maybe didn't see from the presentation before, the agency is still asking for new reports and not asking us to, okay, everybody who wants to accreditate, come to accreditate. They just want to have reports to make a benchmarks, and this is something that is very, very difficult for us. We don't agree with that. We would like to have quality leveling and quality labeling. It means that I would like to have the mark on my practice. This is the practice that have certificate or that is accredited. But we would also like to have a green card, golden card, and deluxe card of the practices, just to promote, to stimulate that you go on and to make some progress, not to start with a minimal criterion and then deteriorate it in some way. And okay, we ask for better collaboration all around, and we hope also the EQUIP within a GP practice in Croatia, within a health system in Croatia, but we also look at the EQUIP for some sort of help. And let me finish with one remark, that we often insist on differences and build barriers between different kinds of doctors, surgeons, GPs, hospital doctors, rural doctors, city doctors, private doctors, state salaried doctors. But I think that we lack to insist on a difference between bad and good doctor, and I think it is also our task to just make that difference more clear and to be so honest that we do it because of our patients, but and also to stimulate the people who want to be better. Thank you.